Welcome to the third session of the special ACE monthly webinar series, Delivering Cancer Care in the COVID-19 Era. Session 3 is titled Imperatives for Oncology Success. I'm Jen Wood, Meeting and Administrative Manager for ACE, and I have a few housekeeping items before we begin. This webinar is being recorded, and it will be posted to the members-only section of the ACE website. We will be pausing throughout the webinar for questions, so if you think of anything during the presentation, please submit your questions through the Q&A box through the Zoom toolbar. Next slide, please. For those of you not familiar with ACE, the Association of Cancer Executives is a national organization committed to the leadership development of oncology executives through continuing education and professional networking designed to promote improvement in patient care delivery. Next slide, please. The ACE membership year ends on June 30th, and we're pleased to share with you that we have launched a new membership platform. Join or renew your ACE membership for only $75 per year. For more information on membership benefits and to join, please visit cancerexecutives.org. Next slide, please. Please save the date for the 27th ACE annual meeting scheduled January 31st to February 2nd, 2021 in Rancho Mirage, California. Sponsorship and exhibitor opportunities are now available. We will be opening attendee registration later in the summer. For more information about the upcoming annual meeting, please visit cancerexecutivesmeetings.com. Next slide, please. Now, it gives me great pleasure to introduce today's webinar moderator, Nancy Bookbinder. Nancy's 35 years of experience working with the oncology community includes consulting and collaborating with hospitals, health systems, physician practices, government programs, foundations, and national oncology associations. In 1990, she founded Oncology Resource Consultants and was the firm's president for 29 years. This past year, Nancy was a principal with ECG Management Consultants and a co-leader for the firm's oncology consulting practice. Early in her career, Nancy served as executive director in both an academic and a community cancer center. She's a board member of the Association of Cancer Executives and serves on the Henrietta Lacks Advisory Board. Nancy is the first recipient of the ACE Marcia Fountain Award for Excellence in Cancer Administration. We hope you enjoyed today's webinar. Please take it away, Nancy.
Thank you, Jen. I'd like to welcome everyone on the line to our third in a series of webinars brought to you by the Association of Cancer Executives for our members. Goals of the webinar today are to share learnings and guidance from our three speakers and to hear from webinar participants. We will pause for your questions at the end of each section of the presentation and again at the end of the presentation. As Jen mentioned, we ask that you forward your questions as early as possible to ensure that the speakers have the opportunity to respond. I know those of us in oncology are not a shy group, so please get those questions into our speakers. We'll forward them to Ryan, Sophie, and Kelley during the webinar presentation. I'm pleased to introduce the Chartis Oncology team presenters today. All three presenters are with the Chartis group and hold leadership positions in the firm's Oncology Solutions practice. Sophie will start us off today. Sophie Clamon is the practice manager for the Chartis Oncology Solutions practice. Her work is focused on supporting cancer providers, set and implement strategic and operation plans to enhance the quality and efficiency of oncology care delivery. Ms. Clamon supports overall management of the practice at Chartis Oncology Solutions. She's responsible for ensuring Chartis's breadth of experience and latest perspectives are brought to each engagement. Sophie brings her background in healthcare consulting across the UK and the US. She has firsthand operational experience in managing large and complex teams. Sophie holds a bachelor's degree from the London School of Economics. Our second speaker will be Ryan Langdale. Ryan's a principal in the Oncology Solutions practice. He works with clients to successfully navigate the complexities of oncology care in a rapidly evolving healthcare environment. He brings robust experience in partnering with hospitals and health system leadership to prioritize program initiatives, interpret the competitive landscape, anticipate emerging trends, and develop sound strategies for long-term growth and strong financial returns. Ryan brings project experience with over 80 cancer programs around the country, and his focus includes strategic planning, delivery network design, physician alignment and transactional strategy, clinical program optimization, and value-based care design. These projects have advanced patient-centric cancer care across a range of academic medical centers, regional health systems, and single community hospitals. Our third speaker, well known to many of you, is Kelley Simpson. Kelley is a director with the Chartis group and is recognized as a firm leader in business transactions, facilitating hundreds of arrangements among hospitals, health systems, NCI affiliates, and medical groups. Her 29 years of experience with the full range of challenges facing community and NCI academic centers allows her to identify high-impact, sustainable opportunities. Her clients value her proven track record of getting the deal done while providing pragmatic counsel and post-transaction implementation leadership to ensure arrangement durability. She serves on committees with many oncology organizations, including the Association of Cancer Executives, the Association of Community Cancer Centers, and she has served on the advisory board of the Cancer Center Business Summit. Sophie, I turn it over to you to get us started. Thank you.
Wonderful. Thank you, Nancy. And thank you for that introduction. And thank you to all of you for joining us today. We're delighted to be here, and we hope you find this session very interesting and informative. So as per the title of this, Kelley, Ryan, and I will be talking through, sorry, I'm having a problem with the screen changing here. We're going to be talking through 3 imperatives for oncology success as you navigate through and after the COVID era. So the 3 of these are reactivate and recapture the patient. So really, how do we bring back the volumes? Redirect your market strategy. So thinking through what are the long-term things we've learned through this COVID experience and how is that going to change what it needs to be successful in the long term within oncology. And then finally, reimagine your care model. So in this section, we'll address the inevitable financial pressure we expect to see oncology programs face, and also how do we leverage that innovation in the care model in the long term to be successful and improve patient experience and outcomes. We have a lot to get through, and we were aware and have given the warning that we do not have a lot of time and to keep the pace. So we will move very rapidly through these slides, but please do feel free to get in touch with us one-on-one after this, while information will be left at the end, and we'd be delighted to follow up on any of these topics. So without further carry on, I'm going to hand over to Ryan to talk you through our first imperative.
Thanks. And I'll apologize in advance that I don't have a British accent. Hopefully I can keep this as interesting as Sophie's section for you all. But I'm gonna tackle the first imperative around reactivation of the patients. So if you can kind of jump to the next slide, I want to lead with just a few of the things I hope folks will take away from the next 10 minutes or so of content. And that is, I think in order to understand reactivation, it's worth talking a little bit about the level of disruption and deactivation that's gone on over the last few months and how that's been experienced across the country. It's certainly been in a pretty heterogeneous way based on our conversations with our clients, depending on where the geography was and what kind of care settings we're talking about. So we'll chat a bit about that, as well as some of the things that were sort of universally shared experiences around volume of screening and diagnostics going away. The fact that COVID is exploiting some underlying disparities in care access, we'll chat about what that means, and then talk about what it looks like given the reality that COVID's not over yet. We continue to see cases spike in many states. It was in the news as of this morning in states like Texas, and it's going to be a pretty non-linear path back to what will be a new normal. And so we're going to talk a bit about how that affects the sections that follow in Kelley and Sophie's content. It's our position that reactivating these patients is certainly mission critical. It's a financial imperative for most health systems, given the role that cancer service lines play in sort of the margin health of the enterprise. And we'll talk a little bit about where we think reactivation can begin and the importance of certain populations and how you think about segmentation. There have been a lot of alliterative action verbs thrown around reactivation and re-engagement and recapture. And as we look at all of those, I think it's important to understand what the human and sort of economic cost of failing to do that might be, and why it is an imperative. And then I'll finish up this section talking a little bit about what the role of the cancer program is in sort of tackling all of that. Many of these services we're talking about in screening are owned by a lot of different groups, both in sort of primary care and specialists, as well as within hospital departments. And so coordination of all that activity is really important for the cancer program. And there are certain messages we're starting to see emerge from our clients aimed at getting people reactivated in the cancer care ecosystem, particularly in that prevention and surveillance space. And so we'll go through a little bit about what we're hearing in the market, and then pause briefly for questions before we pass it on to Kelley's section on imperative 2. So if you want to go ahead, Sophie. I think this snapshot here is meant to show what the disruption looked like, and I know that many of these numbers will be familiar to you all that have read some of the HCAB work, some of the things published by Flatiron, things from the IQVIA group. What we see, if you sort of start left to right here, was incredible reduction in screening, colonoscopy and mammography sort of topping that list, around 90% reductions relative to what baseline expectations would be. And we'll talk more about what that impact is shortly. As you go right there to surgery, there were decreases in almost all the health systems that we work with for COVID surge readiness. Obviously, that depended a lot on geography. Over 20% of the surgery was canceled in about half of the sites, and in hotspots, we saw upwards of 50 to 70% canceled. And even as that starts to come online, it's in a pretty spotty fashion in the places that we work. As you think about the report from Flatiron's 270 practices that are platformed on OncoEMR, and also just sort of anecdotally the experience that you all have in your cancer centers, there certainly was an evaporation of clinic visits in hem-onc practices. I think they showed about a 40% decrease in new patients for Flatiron's cohort between February and April. The decreases in chemotherapy have actually been fairly modest. It's our thought, and we're hearing from clients that it's a bit of a lagging indicator in that there's a lot of activity happening upstream before we get to chemotherapy infusion. And so I think people are waiting to see whether there will be some disruption that makes its way through the pipeline into that area. Radiation oncology is a similar story, being further down the line. There was a little less disruption in this space. And I think there's a question, and we had a client tell us this week actually that they have about 6,000 new cancer cases. They had almost no breast surgery happen for about a 4 to 6 week period this spring. And they're looking at what that means for July and August when those patients otherwise would have been in radiation therapy. And so, I think those sort of anecdotes, be interesting to watch how that plays out in radiation. Surveillance, much the same as sort of screening, right? There's about 22 million screens that were missed by virtue of a lot of this infrastructure being offline for as long as it was. And so, I think this disruption in the aggregate was significant, but it was experienced in a pretty unequal fashion depending on where the health systems are, and certainly by the provider type and the patient type. And so, as you kind of transition to this next slide, I think the reality is that COVID's also revealing some fairly long-standing disparities, just at baseline with healthcare and with cancer care. And this has certainly entered the national conversation in a pretty significant way in the last few weeks. But we've been talking a lot over the last couple of years that even before COVID, cancer care had a lot of socioeconomic and racial outcome disparity just at baseline. The map there is cancer mortality rates, and it's scary when you match this up against a county level view of socioeconomic barriers, and they look almost exactly the same. There's a strong tie between the two, and there's data that suggests that Black men have about an 8% higher incidence rate and almost a 20% higher mortality rate in cancer care than white men, and that Black and Hispanics, as you think about how we advance cancer science and trial, clinical research, that they're underrepresented by orders of magnitude in the patient population that has access to clinical trials. And so all of that has bearing on cancer mortality. And we're kind of layering on top of that the COVID disruption to the right here. And we pulled some data. This was actually published out of the state of New York. And they plotted, on the y-axis, the number of non-fatal hospitalizations per 100,000, and then on the x-axis, the mortality rate per 100,000. And, along both of those factors, there is a huge disparity on a racial basis, and, almost twice as likely to die from COVID as a Black patient than a white patient in this pretty significant data set that they had coming out of New York. And so, we think this all has a lot of bearing on how we think about the cancer care response to these things, and certainly as we think about access. And part of the challenge is, these are systemic issues that won't be, quickly resolved. And they take on heightened urgency given what's going on with COVID and the fact that it doesn't look like COVID is leaving us anytime soon. As you go to the next slide, Sophie, this kind of hits on that point. And we've been using this graphic to the right pretty frequently with our clients to talk about the experience of COVID. And I think, to start off with, everyone had this expectation of uncontrolled transmission, which is that large blue and red pop. And there were places like New York City and others that had that, but more of our clients have experienced that swell, which is sort of the bottom curve. And certainly, you could argue where we are in that swell, but at least in the news today, Arizona's, reporting its highest number of hospitalizations due to COVID. Texas has, 4,000 people hospitalized, almost double the number they had in June, early June at this time. And so, their governor's talking about possible shelter-in-place orders and things of that nature. And so I think each state is going to have sort of their own curve here. But as you look forward and outward, September, October, November, into this winter, a lot of the planning conversations we're having are around what happens when there's a second or third resurgence. How do we handle that series of resurgences as a cancer program? And will it be a bit of an accordion in terms of opening and closing the various sites of care and how we think about screening, prevention, elective surgeries, et cetera? And I think that kind of demonstrates the uncertainty around how we plan for this. So if you could go to the next slide, the implications for cancer out of that view are pretty vast. ACS, reported about half of patients that they surveyed said that, COVID had delayed their care in some capacity. Ned Sharpless, the NCI director, had an editorial last week in Science saying that their estimate is there may be another 10,000 additional deaths just from breast and colorectal cancer over the next decade by virtue of the delays that we've seen this year and some of the upstaging and things that have gone on. And certainly on a financial basis, cancer keeps the doors open in a lot of the health systems that we work with. It provides 20 to 40% of the total system margin, and so as that has gone dark, and to the degree that takes a while to ramp back up, it has some pretty significant implications for the financial health of the enterprise in most of the places that we work. And so all of that sort of culminates in the fact that time is of the essence, and there certainly are some imperatives for cancer programs to think about how we re-engage. As you go to the next slide, Sophie, this is a graphic we've started to use and talk through with our clients, and it really is around starting with some segmentation, recognizing that re-engagement does not look the same across all patient types, certainly not across all socioeconomic or insurance categories, or cancer risk or recurrence risk, or where they are in the stage sort of in the care continuum, which is what we have illustrated here on this slide. And as you work your way backwards on this slide, actually maybe from right to left, we've got the folks that are on active treatment that we think are going to be quite willing to return to the healthcare system. They may never have left really in any real capacity. And these people are actively undergoing surgery and have an active diagnosis of cancer, and are in chemotherapy, radiation therapy, somewhere in that active treatment zone. As you work your way to the left on this graph, you run into two categories or two cohorts that are probably going to be less willing to return to the system, and this is where the real work is going to be around re-engagement. Cohort B being those survivors that are just recently completed treatment and maybe hesitant to return back to care for things that are needed to monitor for recurrence. And then on cohort A to the far left, this is a vast population of people that need routine screening. They're likely to avoid care environments because of a perceived low risk of cancer. And most places encourage these people to stay away for the better part of 2 or 3 months, saying, these things can wait while COVID is doing what it's doing. But as that stretches to 6 to 9 months, it becomes a real issue, not just for the pipeline to keep the cancer program busy and for the health of the service line, but for sort of the human effect of what that means to have cancers go that long undetected. And so all of these groups are going to require, some kind of reactivation strategy, and they're going to have different wants and needs. We're going to leave you with this last slide, which is really around what it looks like for the screening and surveillance group, that cohort A that represents a lot of patients. And, we think it's instructive to see, what the market's doing and what some of the bigger cancer centers are doing. We've collected a little bit of that here and organized by theme. But, the places like CTCA and UCSF, on their front sort of splash page with their websites, they're leading with a sense of urgency, right? So cancer doesn't stop, and neither do we. Don't wait on treatment. Do not put it off. And tangibly, that means identifying, and contacting your highest risk patients, and contextualizing their risk, and leaning on the people that have those relationships to communicate that, and making sure you're reinforcing urgency and all of the communications as they are doing on these websites. I think probably the one that's most pervasive right now is selling on safety. So we have some snapshot there from Moffitt and from the Mayo Clinic. This is the safest place for cancer patients to be. This is your safe destination for face-to-face care. Certainly places like Moffitt that are relatively insulated and only treating cancer patients have a bit of a leg up in telling that story, because you're not having to deal with the rest of the hospital sort of attached to that and all the other services and the perceived risk that brings for patients that are coming into the setting. And none of those things that are listed there around what they're doing are particularly novel. Universal masking, reducing throughput, and creating ways for people to come and get care safely are being piloted and used across the country. Some of these places have the benefit of being able to do COVID testing, and certainly that brings a peace of mind that's tough to replicate with these other mechanisms. But this is a big piece of what we're seeing. And then the final one is to just start with screening. So the James at Ohio State and Fox Chase both have kind of led with messages around specifically targeting the screening and prevention populations. And so, as the cancer program sort of thinks about what their role is in this, it's going to be different. If you're talking about women's services that own screening mammography, and the pulmonologists and others that are involved in low-dose CT, urologists that are handling PSA testing, your OBGYNs that are doing pap smears, colonoscopies in your GI group and endoscopy centers, and all of those are fairly diffuse, and it's fairly common that cancer centers don't actually own those services, and so they do play a role in leading that coordination, and certainly a role in managing the messaging and making sure that these things reactivate in a timely manner, and that we don't sort of see the worst of the outcomes of failing to reactivate patients. May have exceeded my few minutes there, so I'm gonna stop there. And Nancy, if there are questions, happy to pause here. Otherwise, let Kelley move into the second section.
We don't have any questions yet. Again, we encourage people on the webinar to send them on in, and we can go into the next section. Thank you.
Kelley, you're muted.
Thank you, Sophie. Thank you, Nancy, as well. Considering the industry perspective that Ryan shared, we really want to discuss what you as cancer executives should be considering, and as leaders, how this influences how you respond. And so the next slide, as you all know, the industry was already feeling pivot points in care delivery via the interests of new, more prominent for-profit players, as well as continued provider integration. But COVID accelerated those trends with a dramatic market shift away from traditional care models to ones that are more consumer-driven, digitally enabled, and focused on risk avoidance and patient convenience. With the added influence of financial pressures, providers are faced with new threats of market disruption and the reality of determining whether to take an offensive or a defensive position in their markets. So fundamental decisions need to be made about how and where to care for your cancer patients, and contextualized relative to current and future investment plans. Next slide. Principally, we're viewing this with three disruptive factors, which include integration, technology, and policy, and these are all impacting the market like never before. While the legacy model of care was largely constructed around hospital assets and sequential, discrete cancer value chain through horizontal integration, the emerging model is really characterized by an end-user consumer experience, connecting digital and physical care environments. So while integration has been occurring with oncology practices and health systems since as early as 2008, new for-profit entrants are changing the landscape through private equity investments such as Oncology and retail cancer care, with CVS investing in its Transform Cancer Care plan using genomics paired with NCCN guidelines and nurse-led care management to help prevent, screen for, and detect cancer earlier for better disease management, thereby instituting cost savings. Technology providers like Google are advancing ways to increase the accuracy and efficiency of screening programs, as well as reduce wait times and stress for patients through its enabled AI diagnostic detection of breast cancers. Large employers, we've seen, are paying for employees to travel to leading specialists and destination cancer centers. Amazon, for example, in partnership with City of Hope, which then potentially impacts the retention of cases in local markets. And then finally, policy is shaping the financial realities for providers with examples like COVID ramping up telehealth payment, CMS expanding payment for in-home chemotherapy, or through the continued push by CVS of oncology value-based payment models and the lingering considerations of future 340B cost savings. So the convergence of these trends, in our opinion, have intensified with COVID. They were there, but they're further intensified. And it's really demanding cancer care providers to reassess their legacy strategies and engage in proliferation of future state market solutions. Next slide. So many of you are familiar with the Community Oncology Alliance report. In its 2020 report since 2010, more than 1,200 practices have been acquired or have closed. And at the time of the latest report, the most recent 2020 report, it indicates that close to 400 are struggling financially. And this was all pre-COVID. So pre-COVID, market forces like growing number and cost in cancer care drugs was driving consolidation for to get better pricing on a group buy. There were attractive margins created through hospital physician alignment for 340B discounts and commercial rate variables. There's also, a shortage of oncologists in the provider pool that are compelling folks to integrate through PSA or employment arrangements. And others are just using it as an integration competitive edge to be gained in the market. But the new added pressures precipitated by COVID render more consolidation inevitable. So the next slide, these pressures are being seen in the Flatiron report that Ryan referenced. Oncologists are really, it really indicates the financial concerns that oncologists have about sustaining their practices. Considering the new added pressures in large declines in new patient volumes, delays in re-engaging patients, and the changing payer mix with more under and non-insured patient populations, struggling practices will also face their own strategic questions of how best to position for the future. Principally, there are three strategic considerations as you see here. Some may just simply restructure their care delivery models and assets to drive cost containment. And some, we think in smaller practices, will seek viable partners. Of the ones that do seek viable partners, two options really exist in our mind. The first being potential alignment with national private equity-backed mega groups such as 21st Century or Oncology or others. The other is alignment with a hospital or health system in a local market. And so if pursuing a locally based alignment, health systems, we believe, have to be quite nimble to capitalize on program integration and margin accretion. And the ones that had strong balance sheets pre-COVID, we think, will seize on these opportunities first. Next slide. So while traditionally the worldview was patients prioritizing care at destination cancer centers and local cancer centers with fewer in-home and virtual care options. Next slide. Today, the cancer patient, faced with risk avoidance, convenience, and lower cost care delivery options, is experiencing a mind shift in access to care, with virtual health and more at-home care and interventions taking center stage, followed by those local physician and cancer center solutions, with destination centers being further in the rearview mirror for these patients. Next slide. So all of this is leading to what your cancer program strategic posture will be in light of COVID's influence. You know, will you choose to be an offensive strategy that capitalizes on these market changes? Or will you simply defensively strive to protect market position from better capitalized market competitors? You know, the trickle-down effects of disruption during and post-COVID will it push you towards partnering with what may have previously been unexpected market players to strategically capitalize on new ways of doing business? These are really essential questions for cancer providers. You've got to consider these when advancing your strategic agendas to act with agility and maintain cancer as one of the top service lines contributing significant margins to your health systems. So before Sophie discusses reimagining your cancer care model, Nancy, I'll pause for any questions.
We don't have any yet, Kelley, thank you, but we'll continue to monitor.
Thank you.
Well, I hope you do all come up with some questions, or you're going to have to listen to me go very slowly for 30 minutes over this last section. So our final imperative is to reimagine your care model. And so, like the others, there's a few key points we'd like you to take away from this section. So firstly, the financial pressure. So usually, you know, while we talk about oncology as being a margin center, I think it's very likely we're going to see health systems put sweeping cost reduction and margin pressures on all service lines, and oncology is unlikely to be immune from that. And so we just want to spend a little bit of time thinking about what thoughtful things could be done in order to, you know, best set up for the long run care model and optimize for that and minimize patient experience with those margin pressures. And then secondly, touch on telehealth. So we've seen an absolute explosion of telehealth in the beginning of COVID. And so we'd like to spend a few minutes on where do we think that is, you know, more or less going to land, and what that means in terms of how you think about the care model and the long-term strategy. And then finally, we're going to end with some points of innovation. So we've seen a lot of very exciting innovation take place in the last 3 months within cancer. I think a lot of people have likened the last 3 months innovation to be at least, if not more so, than innovation over the last decade. And a lot of that isn't going to go. You know, the oncologists have gone over there. For providers have become used to it, and patients have started to expect it. And so we're going to talk through a little bit of the innovation we've seen, and then double click onto a couple of those that we think may well stick. So firstly, into the financial pressure. So, you know, again, we're expecting to see oncology be a financial steward, as with other departments, in light of financial recovery for health systems. And so there are 3 things that we encourage you to do. And, you know, the main thing here is that to be as thoughtful and as analytical as possible when we start thinking about cost reduction. And so, you know, often it's, you know, we see mass unemployment or sort of wholesale cutting of supporting programs. And so really wants to sort of be able to take the time to look analytically at what those are. And so the first one there, improving resource efficiency. So really making sure that as we make these cuts that we're right sizing the ratios of staff across infusion, radiation clinic, pharmacy. And that's both against external benchmarks, but also for the larger health systems where there's multiple sites of care, you know, looking at those are consistent and best practice. You know, physician compensation, never a popular topic, but at least in terms of that, to make sure that the incentives of physicians are aligned with what may now be revised goals of the overall program. And again, looking into how can we leverage digital in terms of all of the touch points. And then second in there, the front and reviewing of front and back office. So, firstly on sort of more of the revenue side there. So, making sure that collections do match contracts, which, sounds fairly obvious, but I think we often see, a lot of opportunity when you just dig into some of those numbers and make sure that we are, rightly collecting the revenue, that doing some benchmarking around the drug spend, to take the opportunities there that don't have any impact on people or on patients. And then the second point there on automation and cell stream, and this is a topic that comes up a few times as we look at some of these safety measures that we're implementing for COVID. Some of that is going to change the staffing there, and so that point on automation is when patients are coming in, if they can be doing everything digitally in terms of paperwork, check-in, and everything else, that may have pretty big impact on what our costs there in terms of overhead, and being much more efficient with that element. And then finally, rationalizing non-revenue producing programs. And again, this is a sort of easy one, and they're often the first hit in terms of non-direct. And so again, the urge is to be thoughtful here in terms of what these programs are, because many health systems and many oncology programs have worked pretty hard to build these up, and for very good reason, and put a lot of investment into them. So, before we wholesale take them out, thinking about what are the KPIs, how do we make sure that the KPIs in those programs are optimized in the new world that we're working in, to work directly towards the overall clinical goals. And again, we touched on this. Of those, if they do go, or some of those services are rationalized, how many could be moved, and in what way could be moved to a virtual alternative that could be cheaper to deliver, but would still deliver that, those very important services to patients. And then on the second point, so onto digital health. So, we saw, a real explosion of digital health at the start of COVID. There were some pretty mind-boggling numbers released through the early part. I think Novant Health reported going from 200 visits a year to over 12,000 in a week. Moffitt Cancer Center said they increased virtual visits by 5,000%. And so, we saw this sort of massive spike, as this chart shows. And then, sort of interestingly, we started to sort of see the chart come down again, I think, as the sort of initial fears and some of the kind of rearrangement of safety precautions have allowed some of those visits to go back to being in person. And while we can't claim to know exactly where this graph is going to end, I think we can all very, very confidently say it is not going to go back to the 0.1% that it was in January and February at the start of this year. And so, that has sort of very broad impacts as we, look to what models in place. And I think, it's been a fairly tough learning experience, I think, for lots of people to very rapidly come over the hump. But now we have physicians on board, and the patient feedback that we've seen has been pretty overwhelmingly positive. And so I think we sort of, now that genie's out the bottle, it's not going to go back, even if it doesn't stay at that that very high 25% share of visits it got to. And so what does that mean for health systems? So a number of things. Firstly, we are seeing, and we are going to continue to see, the technology around digital health advance very, very rapidly. There's the demand will stay high. And so, keeping mindful of what the best technology is out there, and keeping very watchful of how that integrates with all the other technology and all the other advancements that's coming to be fully integrated and efficient. Secondly, obviously has pretty big implications on facilities, staffing, equipment. If we're seeing 10-15% less people coming through the facilities, that has a pretty decent impact on throughput and the sort of the staffing and the teams and the experience we need to make those digital visits as efficient and as effective as in person. Redesigning appointments, and again, this is one that's been a fast learning curve on, but how do we make sure that that the check-in process, the technical checks, and those visits are run as smoothly and as efficiently as they are in person? I think people's willingness to wait and expectations in front of the queue kind of slightly changes to in a waiting room, or from one a nurse check-in to in person. And so how do we make sure that is all smooth, and that the scheduling and everything else is done in a technical manner? And then final point there, almost jumping back a little bit to Kelley's talk about strategy, digital may have a fairly large impact on terms of competitive and geographic barriers to entry, as we see. It's a lot less overwhelming to take a provider who is further away if you're only going to see them for half or even less of your visits, if the rest can be done virtually. And so we may see people be more willing to look more broader at their health options, more willingness to travel for those key appointments, and/or some pretty interesting partnership models that really leverage digital. And then innovation. And so And we've seen some really interesting innovation going on that have been very quickly entrepreneurial health systems have been putting in place to make sure they can continue to serve their patients, make sure that particularly their active patients can remain on their treatment schedules, and that they can keep that patient experience high. So there are 4 themes that we've seen, and these aren't totally meaty. There's some overlap between them, but the first of those alternative care settings. So we've seen a lot of really interesting things happen around drive-through port flushes. So what can be done from someone's car just to avoid having to walk into a hospital, potentially see someone else in an elevator, someone else at check-in. What can they do to keep people out? And then we started seeing some care move to in-home, and I'm going to do a double click on in-home chemotherapy infusions in just a moment. And then secondly, telehealth, going back to what I just talked about, I think the one point that's interesting to add to this from what we've already said is, that clinical trials. So we're starting to see more clinical trials really embrace telehealth, and that's, I think, a very exciting change, because that, it can be pretty burdensome to sign up for a trial. It can be a very heavy commitment from a patient in terms of time, travel, number of appointments, number of reporting. And so with these sort of more options coming up to remotely engage in these trials, more information, we could see some really interesting results, and even potentially quicker advancements in care. Safety assurance. So safety is obviously, as Ryan touched on, it's a huge theme across, and so anything that can be done in terms of minimizing exposure. For example, the bottom one there on the virtual waiting room. Previously, I think patients would walk in and the pen and clipboard that seemed totally innocuous, and now they're kind of looked at as hazard items, and as is the person behind the desk. So there's been a number of moves we've seen there around how do we just minimize exposure. That I think will be here to stay, and while the immediate threat of COVID will decline, and COVID won't be as overwhelming maybe as it is now, it's not going to go away quickly, and there are always other things. And with our immunosuppressed patients, it's always a good thing to be keeping them as safe as possible. And then our 4th theme there in terms of multimodal connectivity. And some of these are fairly basic. One of those, there's the top one there on iPads and FaceTime. That was really just around a patient being given the option to FaceTime with her support person at home, but that they did it in a way that they set up the iPad to be really able to speak to them, and that the staff were very open and willing to connect and communicate with that person to help as if they were in the room. But that makes a huge difference to the individual patient experience, to feel like someone's with them, and to have a second person who is listening firsthand to what they're being told about their treatment, what the physician is sharing, what the nurse is telling them. And so some of those things I think are less disruptive, but just sort of a little bit of effort in terms of pre-communication and a small amount of training. So to end for our presentation, and we really hope you've got some questions for us at the end of the slide, so get thinking if you haven't, is one to double click on in-home chemo infusions. And this is a topic we've done a lot of thinking about, and it's a really interesting one. We've seen in-home chemotherapy infusion done fairly successfully in other countries. So the UK, it's pretty big. Australia, Denmark all have pretty established programs for in-home chemotherapy infusion. And we've seen a few isolated trials in the US that have been very successful, but there have been a number of legacy barriers, and COVID has created sort of the perfect storm to start to break down some of these barriers. And so I think we're going to expect to see it. In-home chemo infusions, it doesn't need, it's fairly obvious what the benefit to the patient is. You've got these tired immunosuppressed patients, for them to not have to sort of do the travel, the pathfinding to get to the infusion center, and to be in the peace of their own home, surrounded by things that keep them comfortable, and their support person is, it's an easy sell for a patient, and so it isn't a surprise that the patient experience from patients internationally and who've been in trials in the US is overwhelmingly positive. But some of those barriers are coming down, and so to pick on a couple of those, we've seen regulatory changes. So CMS has been doing a number of changes that equalize settings of care, and so that opens up reduces one of the financial hurdles and the regulatory hurdle, and to be able to deliver chemotherapy in home. Care continuity, that's really been a feature of COVID particularly, where there's been obviously a huge need to continue patients on their care path. So cancer patients currently receiving treatment, and so that has been an option to move them in home versus to bring them into the health systems, especially those that are in high exposure areas. We've seen, we know there's capacity constraints in infusion clinics, and so a sort of strong option to move out to use another setting of care is, I think, very appealing to health systems. Again, the international success I mentioned before, that they show that there are models to deliver that. Most of them use sort of home infusion private companies to do it, but they have very, very strict safety regulations, very, very clear protocols about what to do in case of which infusions can be done, and then very clear protocols of what would be done if there was any side effects. And obviously, kind of the game all stops with financial viability at the bottom, and the finances are complicated, and we certainly encourage the first step in terms of looking at that is to do that financial analysis. But what we've seen from studies that have been done is just because overhead costs of in clinic chemo infusions are so high that actually it can be done at half the cost in home. And so while obviously the reimbursement we'll be looking at, I think we expect to see, particularly the financial pressures, that there may well be some payer pressure to start to embrace new settings of care where they can be shown to be beneficial to patient experience and safety is fully managed. And so we think this is a pretty exciting topic, and keeping a close eye on its adoption in the US. That brings me to the end of this section. Any questions? I don't know, to ask on this or any of the topics we've discussed so far.
Well, we have two questions addressed to all members of the panel. The first question is, what is your prediction of CMS continuing to pay equitably for an inpatient visit, or to an inpatient visit for a telehealth visit?
It's a good question. It's a contemporary question. I think there were hearings going on this week, and some bipartisan sort of Senate committees talking about trying to put some pressure on having permanent changes made in reimbursement for telehealth and getting that fully baked in. I think there's sort of anybody's guess, but it does have broad support, and a lot of the sort of the traditional barriers that have been thrown up around demonstrating that it can be effective, demonstrating that it's cost effective, the outcomes are okay. There's going to be a body of evidence, obviously, from the last couple of months around what that experience looked like and whether it was efficacious. And so hopefully, those sorts of things will get worked out. But there are other pieces that, people talk about state licensure barriers being an issue as you sort of work across state lines with digital health, talk about commercial reimbursement, fraud and sort of data privacy and safety. And so there are other things to be worked out in addition to kind of just permanent changes to reimbursement. But it's being actively discussed, and I think we'll probably have an answer to that pretty soon in the next month.
So Ryan, you walked right into the next question. Would like to understand some of the strategies to overcome barriers related to digital healthcare with state boundary issues and licensure. Any ideas on changing policy in this space?
Yeah, I'll probably have to kick that to the policy experts on how you get around that. I think the issue is obviously well understood and has been probably one of the biggest barriers to telehealth expansion over the years. And it's going to have, unless there's sort of federal mandates on eliminating state licensure barriers, it becomes a sort of an exercise in getting state waivers, right? And that's going to be on a state-by-state basis. And so, I think in an ideal world, you'd get federal action on that, some kind of compact to kind of change that on a more global basis. But I can't sort of speak intelligently as to sort of what the policy folks are doing to try to be change agents on that issue.
Kelley, thank you very much, Ryan. Those are the questions that have been submitted so far. I think, Kelley, you were going to provide us with a summary.
Sure. So thanks, Nancy. So in summary, obviously core to your all's mission as cancer care providers is recovering and serving the patients in your communities. And COVID certainly presents a new normal, certainly in the foreseeable future. So I think, we must lead, you all must lead in signaling safety and redesigning your care processes. COVID's only accelerating the trends, reshaping the industry, and youth executives really must acutely understand these and embrace those changes. Doing so will position you to successfully drive your market strategies, in our opinion. Steps to kickstart your thinking should include making virtual care a permanent element of your care delivery model, really ensuring that your short-term efforts lead to longer-term adoption of care model optimization and efficiency. You know, leveraging your APPs, leveraging your survivorship clinics, leveraging your digitally enabled care model, embracing innovation and exploring options for differentiating your patient experience. And then also considering some opportunities with non-traditional partners along the way. You know, it's certainly challenging times, but with challenging times, that brings the most empowering lessons. And I think, you know, all of us are learning new lessons in this era. So we really thank you for your participation. We hope the session's been informative and helpful. And we're happy to take any questions now, or on the next slide, we've shared our contact information, and you can reach out to any of the three of us if you have any questions post-session. These slides will be available on the members only section of the ACE website.
Well, I'd like to share a comment that just came in, and you've had two of these. Thank you for a great presentation. We would like to thank all of the presenters today for taking the time to do this and putting these materials together for the membership. We'd also like to thank everyone who participated on this call today, and hope you can join us for the next ACE webinar in the series. That will be at the end of July. We don't have our date yet. It will be presented by Taylor Med, and the topic will be how COVID-19 is impacting oncology administration and how to build a more sustainable practice for the future. We also want to encourage and welcome our ACE members to submit webinar presentation proposals. Again, thank you to our panel, and all of their contact information is here for any follow-up that you may have. And we look forward to our next seminar next month. Thank you all so much.
Thank you.
Thanks, everyone.
Thank you.